Thank you very much, Dr. Kofi. It's a pleasure to be here, and thank you everybody for joining us after the work or before the work, and to talk about this very important topic of the shock and hypertension and using the actual ultrasound for it. But I'm trying to talk a lot more, not focus on the ultrasound. And when we are reaching to the actually the content of the shock, explaining a little bit more and make sure we are all on the same page. I apologize if I am not going to just talk about the basics of the ultrasound for cardiac and for lung and for IVC, but I am pretty sure you guys are all familiar on a daily basis. You're using it. I am pretty familiar with your practice. I've been working in different part of the continent for mostly in East Africa, and for a couple of years actually doing the clinical, doing teaching at the inside. So I'm seeing your patients. I'm pretty much know just a little bit at least I can say about the practice that you are doing. So we picked this Roche exam to talk about because it has actually multiple components of the ultrasound that we are learning. Is on daily basis we are using it, and this is one of those applications that I can say if you use ultrasound 2 to 1, you are changing outcome. Outcome does not mean mortality necessarily, but different outcome for the patient, from morbidity, from your uncertainty, from time to treatment, all can be affected by this protocol. And so it's impactful, it's time-sensitive situation that patient needed and you needed, is helping you. And basically there is no alternative in real time. So patient in shock, you are not sending, even if you have a CT scan, MRI, echo, you have no time and you cannot send the patient out of the emergency room to actually do any of those testing. So that makes it more impact and more important to learn how to put this into equation and integrate it in your clinical practice. So this is all I talked already. So this is very critical. And then the other thing is, for all these cases that we are dealing with shock, immediately first thing come to your mind is to give some fluid, bring the blood pressure up. But this is one of the most complicated actually decision that you are making blindly by just giving or not giving. You are saying, okay, this patient I think has heart failure, let's just stop not to do it. But we have a personalized and individualized kind of situation that cannot be randomly decide yes or no fluid or how much fluid to give. So that is make it very important to stratify patient based on the current status of volume and go from there. So why are ultrasound we are using? The other one is that to see for 4 different reasons. One of the main reason is if we can identify the source and the pathophysiology for the shock. Is this the patient has sepsis? Is the patient has cardiogenic shock, that they are basically working completely on two aspect, two spectrum from the actually the management that you want to do. You are looking to see volume status, and more important, you are looking to see if the patient is fluid responsive for the one that you want to do it. You do not want 3 hours of providing the fluid, treating the patient, and after 3 hours, you find out, oh, this patient was not fluid responsive. And guiding all the treatment that we have, you are just putting the probe, you identify that actually precardial effusion as a source of shock, immediately you grab the probe and just your needle and you do your precardiosynthesis. So it's help with the guiding the treatment that you want and the procedure that you need to do. Basically, if I wanted to say, why am I using, excuse me, why am I using this? Is yes for mortality, yes for morbidity. But if I'm saying that actually, if I'm not doing ultrasound, this patient is dying, probably is exaggerating the role of the ultrasound that we have. So using that outcome may not necessarily say the same thing for a lot of other technology that we are using at the bedside. So it's not necessarily about ultrasound. So it's hard to really pinpoint if this ultrasound I did clearly actually end up saving this patient or not. But what you can say is that is helping you with uncertainty. As an emergency physician, as the people that we are working in ER, uncertainty is one of the biggest challenge that we have. So you do not know what is the situation is with this patient. We do not know the situation for heart. We do not know if this patient has the source of sepsis. We do not know. A lot of non-know. And just like you do based on experience that you have, based on pattern recognition you have, and obviously based on knowledge that you have. Two is the balance between the benefit and the harm. First thing you don't want to harm patients. So when you are just randomly giving 2 liters of fluid or not, I don't know, that 20 cc per kg, all those numbers that they are coming, is not necessarily is work one size fit all. So it means that need to be personalized, and that's the ultrasound that help with. Let us start with the one case that I want to talk. I'm sorry if I'm just coughing a little. This is the real case I had actually. This 63 years old man sent with a history of colon cancer, hypertension, and recent pneumonia. He's been sent to be admitted for pneumonia, had been treated in patient. Patient had a blood pressure of 70/50, heart rate of 125, and the temperature of 38 O2 saturation of 82%, elevated JVP, and rails by basal. This is the X-ray I got. Patient clearly had pneumonia and has been treated for pneumonia and is almost accepted for admission. What do you expect to see if you use the bedside ultrasound? I know you guys all want to say, oh, but the heart looks big. I think may have a profusion also. It definitely looks like that in pneumonia. And even maybe a little bit of just right side is completely actually obliterated. And you put the probe, and these are the picture you are seeing. As you can see here, to the left upper corner here, this is the proximal long axis view of the heart. And you see a large precordial effusion all around the heart. Despite the fact that you see a large effusion, you don't see much of the collapsing in the RV in here. You expected with this pressure, with the tamponade that we expected, this one be collapsing, as you can see here to the left side. To the left side here, you see this one actually is a tenting, but not really completely. You look at the IVC, is the plethoric, you see that actually effusion. So you are seeing that is actually what we've been thinking about the X-ray is obviously correct. Two things is come to your mind. This patient has history of colon cancer. Is this possible this patient has PE? Clearly. This patient has this actually large effusion. This patient is suffering from atelectasis. Yes. And why the RV is not collapsing? So this patient actually got a CT scan for further evaluation finally. Patient has confirmed pneumonia with even positive culture. Patient had large precordial effusion, and the patient has saddle pulmonary embolism. The reason that you see that is actually like really right now, the pressure is not pushing on the RV because pressure inside is high and is preventing collapsing of the RV, despite the fact that this patient is in severe actually tamponade. So for all different stages of the actual shock resuscitation, we talk about the monitoring and management and helping you with management. The management, as you can see here, the first thing we do salvage therapy. We all want to just push the fluid in as much as you can. We start it as fast as possible. We start the antibiotic as much as you can to get the blood pressure greater mean of the greater than 65. The start vasopressor fast. Then after you started this one, you optimize it. You see, okay, this time now, let's just look back. So how much fluid this patient got? Okay, this we need more or less. How much pressure is that? Do we need a good, is that the second person need to start it? All those things and stabilizing it. So now, okay, we are good now. We are going to just put the low dose of pressure and we have a lower dose of like actually fluid and we stabilize this one. In all these ones, monitoring happen with echo, 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 echo. Even for the escalation, we all need actually like the echo to decide if we want to hold that actual pressure, if we want to start a diuresing now from the fluid that we are given, or any other de-escalation actual factor that you want to do. For the sake of the actual classifying, not all these patients can be classified as one category. Majority of these cases, they have all multiple things together. Patient has history of CHF, now is come with the sepsis. Patient is at the severe dehydration and sepsis on the top of that severe diarrhea the patient had. So those are combinations that you can't really put them on, but it's good to know some classification that we have. One is the hypovolemia, that you can see that typically we go with the cases of hemorrhage, cases of dehydration. So you are giving the fluid, you give him blood, and then we go from there. Obstructive one, you have RV failure, we have a pulmonary embolism, you have a tamponade, and you have a tension pneumothorax. All that treatment is different. For cardiogenic and distributive. Distributive is the mostly the sepsis on the top, and you have the cases of neurogenic and cases of anaphylaxis. Those are the main one that we have a distributive shock. These are the ones that actually the treatment is much different from what you all want to do with the hypovolemia that we talk in a second. So I could put this all the shock protocol. So they say, as you can see, we do not know what is the obvious reason for shock for this case. Basically, we are dealing with undifferentiated shock and undifferentiated hypotension. So to have this one, if I don't know what is this coming, I need to actually start investigating different part that could be the source of that actual hypotension. One of the most important part that can give you tons of clue about the source and about the management is the cardiac part. Not necessarily to complete all component of the ultrasound. You do not need to just do all the view of the heart for the identify it. If you identify in one or two and identify what is going on with the patient, you can simply actually start acting for that. The second one is that the IVC. You need to know what is the status of the fluid reserve, not the fluid in circulation. This is very important to know. What is matter is the fluid. It means that actually pressure and the dynamic of the intravascular volume that matters the most. But as a surrogate, we look for IVC. IVC is your storage, okay? So your storage of the water in your house, you're looking at, you say, okay, the storage is full, so probably they are good, so the circulation may happen. But why if I tell you that one of the, the hose that is sending this one is leaking, the patient has sepsis. So how that IVC can represent volume status for this patient. So those are the downside for the IVCs. But still we are using it because it's giving you some component of the actual information about the volume status. You do a fast exam. You look for the intra-abdominal, intrathoracic fluid as a result to see if the source is the bleeding intraperitoneal. You look for aorta to see if the patient has the aortic aneurysm or dissection leaking around it, and those are the ones that can cause. And you look for the pneumothorax. Or do you think this all of them they have the same value for a patient with shock? Absolutely not. So patient with a pneumothorax, you can see 1 in 150 cases. Or the patient with a cardiac, almost every 2 cases that you scan, you find something new. But these are the one mainly the component of the actually like the shock protocol plus DVT that is actually that's part of the rush. They try to actually just simplify it, say, okay, we look at the pump, we look at the tank, we look at the pipes with those ones. Those are good to understand, but it's really not going to be that much really help to see it. There's a mnemonic for it, this they call that high map. You look for the heart, IVC, Morrison pouch, aorta, and the pneumothorax. Important, it's good to know, just remember that those high map. You bring up the map, basically. But not necessarily this is something specific. Let's focus. We said that cardiac is the most important part of this actually rush protocol. For the sake of this only shock protocol and shock evaluation, what we want to know about the echo and shock. Number one, we said you do not need to have a comprehensive echo. Majority of the cases, a lot of cases, especially older patient that you guys seen it, they have a history of smoking, COPD, and if you look at the scan, most of these cases, subxiphoid view is the best view they have. You basically, all you have is good subxiphoid, and the rest of them is hard to really even capture. Can you decide based on the subxiphoid? Absolutely. If you're looking for, what are we looking for? Looking for precardial fluid, yes or no? Looking for ejection fraction. You can see, obviously, apical 4-chamber is the best, but other views I still can tell you if the LV is functioning, non-functioning, or low functioning. Then you are looking at the right side of the heart to see RV is a lot. We are just simplifying it. There's a lot of measurement to identify is the RV dysfunction, but I'm trying to just simplify and say what we are thinking. And looking for the IVC dynamic that you are having. Okay, so you see this is IVC is collapsed, IVC is super dilated, or IVC is something in between. And is the heart preload sensitive? This is another cases that we want to say for those cases that they are like they have a reserved ejection fraction, but the patient is still in shock. Those are important because all the cases with diastolic dysfunction, you want to see that actually this patient has a tolerance for fluid. I did not call that the fluid responsiveness. Okay, all I call here tolerance is this patient can tolerate if you give a 2 liter of fluid or not. Let's review one by one. In hypovolemic, hemorrhagic, and sepsis, at the beginning of the sepsis, all you can see here, you have hyperdynamic LV. Your LV is functioning too much. It's just like an empty LV. It's just functioning, but there's not a lot to send out. The small underfilled LV, and you have also, you see is completely emptying the LV. Towards the end of the systolic, you see in this picture, the free wall and septum kissing each other as a result of the over-emptying actually. So there is no residual in here. Everything is going out, but the still patient is in shock because this patient is underfilled LV. And that's more important than even IVC flat. Because IVC could be even in this case, just like I had 2 cases 2 days ago. RV and the LV, RV and the IVC super dilated as a result of pulmonary hypertension patient has. But the LV was actually underfilled and patient was hypotensive. If you look at the one cases of hypovolemia, you see that actually how this in the this is the short axis view. and you see how much is actually getting together. So the first question I know everybody right now has is this. Okay, you say this hypovolemia and sepsis, they have same picture. Yes, at the beginning they have same picture. Okay, so the vasoplegic is basically sepsis. The sepsis, let us start to remember this now. The sepsis is the disease of vasculature, arterial, mostly arterial. This is just like assume that you have vasoplasia and everything from that actually the artery is leaking. Therefore, your heart is pumping good. You have no problem with the heart. You are giving the fluid, but fluid is not reaching, the blood and volume is not reaching for the distal organ, is not reaching to the actual kidney, is not reaching to the brain, and that vasoplasia. And the main treatment of vasoplasia is vasopressor. You use a vasopressor to fix that vasoplasia, but you need to have a little bit of fluid already that make sure you are not pressing on the empty vasculature. So for these cases, LV ejection fraction, normal or hyperkinetic in both of them. So as you saw, as we discussed earlier, LV is hyperdynamic or normal for that. And when you look at the LV end diastolic actually diameter or area that you have, LV end diastolic area, for vasoplegic, most of the time that LV end diastolic area stays the same. But for hypovolemia, you have that kissing area that actually just completely collapse. So the LV and diastolic area stay stable a lot of time, but for hypovolemia was significantly dropped. The other thing that you have is what is matters on this one. So when you have that area stabilizing, it means you barely get a problem with LV outflow tract obstruction. LV outflow tract obstruction we typically see with the patient with HOCM. Basically, what I'm saying here is this. In the cases with hypovolemia, you are seeing some minor, minimal trace component of the LV outflow tract obstruction, similar to what you see in the patient with HOCM. Because area that the fluid area near the outflow tract is near empty, completely empty. But for vasoplegic cases, as we discussed, because they have preserved that area, is less likely to happen. Can we measure this one? Probably not. So next, we want to talk about the cardiogenic shock. So for cardiogenic shock, obviously the pump cannot pump enough. So you have, regardless of how much fluid you have, how intact your vasculature are, but the heart itself is not functioning 100%. You have a low ejection fraction for these cases. So low ejection fraction that you have is caused the low perfusion at the end. So patient is cardiogenic shock. What you see a large dilated LV. That's number one. Two, you see hypocontractility on the LV. And three, you see the dilated IVC also. And if you look at closely, in this one, you see that in the liver and the IVC, you have a retrograde flow. You are expecting that flow from the hepatic vein to actually drain into the IVC, but as you see here, it's completely reversed. This is the reason when you are doing physical exam, if you remember when you push on the liver, you have the hepatojugular reflex, basically. So next we want to look at this RV overload, the right side. So you have a right side is obstructive because obstruction is happened in front of the pulmonary artery. It's not the LV, but the obstruction happens. So is the circulation is being obstructed, not as the result of DVT, but as a result of clot in the pulmonary artery. And as you see that everything behind retrograde to the pulmonary arteries get dilated, including RV. RV is dilated, is caused that actually septum and pressure goes up, initially just volume. You don't see effect on the septum. As soon as that volume get bigger and translate to the higher pressure, that is caused the septum to be actually deviated to the LV. When it's deviated to the LV, you are seeing that the LV is not filling. There's no enough room for the LV to fluid to come, even the all LV is normal and want to function. And that's why you are just getting a lot of hypertension as a result of this. You see that D sign, that the septum completely deviated to the RV. And that's the main reason that you see these cases, they are coming with shock and hypotension. This is another picture of the cardiogenic one. You see dilated RV in here. Okay. So next we focus on another hypo-obstructive one, the obstruction around the heart itself. So it's obstructing around the heart, but does not, the flow is not going around the heart. Why you call that obstructive? Is obstructive because that is causing pressure to the RV and now is not letting RV to fill. So that is the reason for this one, that is tamponading and causing the patient to actually have a low blood pressure and has a shock as a result of this one. These are the key cases of the RV. What you see when you are having the precardial effusion, remember, precardial effusion is important to know, is not about the volume. The balance of the precardial pressure is a source for tamponade or no tamponade, or for the clinical picture of the precardial effusion. So what I mean, if you focus on one of this one, let's just focus on this one. So left side, you have a pressure of 120, 100. You have a pressure in the right RV is maximum is 25. When you are having the fluid here during the diastole, your 120 millimeter mercury pressure is pushes into the fluid and push that pressure transmitting to the other side because it's a lower pressure. And that pressure inside the precardium is greater than 25, so collapsing the one that has only 25. That's why in the first case, we said that it did not collapse it because the pressure was up as a result of pulmonary embolism, and the pressure already was like 40 or 50. And that's the reason when you are just having that temper, the precardial effusion, not necessarily collapsing your RV. This all different to see. That's one, like the bottom part. You see how much fluid is accumulated here, but this patient not necessarily has tamponade. The reason is that pressure matters, not the volume. What you see right now, this is a picture of one of the cases, I think is Malawi. And what you can see, all you can see, okay, all I see is the super enlarged global precardial effusion and the heart. You put the probe, that's the one that we had at the time. This is like V-scan, and you see a large effusion around the heart, and the patient is in shock. Then you say, okay, decided you want to actually like do the precardial centesis. You actually look and you put this in here. And you started from the beginning here. This is, oh my God, it shows a long time ago. It's 2014, 10 years ago. Okay, so here, look at the timing, 10:18 and 10:47. And you can see here, we put the needle in, we put the catheter in. This is the catheter is coming here. This is the catheter is here. This is the catheter is here. And you see this is the zero effusion around in here, almost zero. In less than 20 minutes, cardiocentesis is done with no pressure, simple as this. And one thing we did in this one that later on I used it a lot, confirmation of that actually the catheter that's inside the precardium. When we go in, it's very hard sometimes to identify the path of the needle because you are going to probe in here and the needle is going right parallel to that. So you are not catching up with the tip of needle, shaft of the needle. When you are going in the right direction, as soon as you can get into the actual precardium, you can inject a little bit of saline, and that is caused that actually the agitation in the precardium. And that precardium, you can see that agitation inside. If you do a little bit more, you know this is not in the right place. We use that agitation. Agitation is not agitation, it's nothing else. It's just the movement of the flow in the like normal saline. We use that to confirm the patient has central line in place. So you just inject a little bit of fluid and you see all of a sudden, simultaneously, RV and RA is filling in, and you know. We use the same thing here. You can use it the same exact thing for the thoracentesis to confirm the catheter in the right place. Okay, let's focus a little bit more on the septic part. Septic part, we said that, as you can see here, is actually like getting together, is the hypercontractility, and there is not a lot into it, but most of the time that the area near the outflow tract is preserved. Okay. Some of the picture of the cases with the septics. We talked about this one. Everything that you saw in the beginning is just at the beginning of the sepsis. If the patient has SARS or has this kind of advanced shock and for a little bit prolonged, so we have something they call that septic cardiomyopathy. So this is actually direct impact of the sepsis on the heart, basically. And this is not just the myocarditis. This is a septic-related cardiomyopathy as a result of the interleukin or whatever that is that. They have a lot of pathophysiology that they are discussing now that I do not want to just go into it. But those are the ones you see. These cases they have the decreased cardiac output overall. You have the LV dysfunction. Majority of them, they have the ejection fraction less than 45%. And you see the complete picture of the like cardiogenic shock as a result of not functioning, not having the LV. Two, because it's globally affecting the heart, RV also is affected. And the RV that affected is you see this RV-LV ratio is going up. So it's globally, you see that the systolic function of the RV and LV involved. At the same time, the diastolic is involved. So you have the same cases that the LV is not functioning and there is not enough room to open up for the fluid, for blood to come to the LV. And when you are doing all the component of the diastolic dysfunction, this patient has it. So a component of the RV, right and left side, systolic and diastolic, that make it called the septic cardiomyopathy that you see towards the end. Those are the cases that actually you can think of just starting that, like ECMO. Those are the pain if you have, and started looking for it. So these are the actually different component, different clinical presentation of sepsis. As you see from the majority of these cases, you are picking up at the beginning. So never reach to that point. Why we don't have that sepsis, the cardiomyopathy? Because they are super sick and nobody has started doing a study, and mostly nobody in that area you can do randomized kind of controlled trial for the cases that they have 50% mortality. You can't randomize control trial. You cannot do that a lot of it. And there's not a lot of them because majority of them, they have been treated before reaching to that point. So that's why you see there's not a lot of work on that septic cardiomyopathy that we can actually tell you right now. So one component I want you to all remember here, this is very, very important. And that is the use of ultrasound in different one. If everybody that is coming to your ER for any reason that blood pressure is a little bit less than 90, and typically you're given leader and just 120 and done. So you say, okay, what ultrasound help with this? Zero. Yes, agree with you. In the cases that they are mild to early, just low, moderate, ultrasound is not significantly impact. But when it's getting moderate to severe presentation on any level, your impact of ultrasound is huge and significant. It's not proportionally going up, significantly increased. You just see that precardial effusion that caused tamponade, then done. But if the patient has a little bit of trace effusion and you find it with ultrasound and not even affecting your high blood pressure or anything related to that, so who cares? You know what I mean? So that's very important to know towards the end. So a lot of those cases that they are sick for a long time, it means severity went up. Patient has been 4 days of patient has diarrhea for 4 days. Patient has like a cardiogenic shock for 2 days. Those are the ultrasound is much more important and impactful than the every overall that you show. This is true for majority of all other sonofield kind of application, the ones that the actual ultrasound didn't have. Appendicitis, the same thing. Diverticulitis, the same thing. Pericardial effusion, the same thing. When you are getting towards advanced, the easy to identify, you are not going to miss it regardless, and the impact is much better than just overall. So basically, you guys all we talked about this one, we detailed this one. I'm not going to go and talk in detail. I just want to show you this picture also. Focusing on that cardiac, on the patient with shock. So if you see hyperdynamic and poor feeling, we already know this is just either this patient has hemorrhage as a result of dehydration, or this patient has sepsis. You see the dilated and poor contractility. You look if this affected the LV. This patient has right-sided the patient has MI, or is the patient has just like a CHF as a result of an exacerbation. If it's RV dilated, you're looking obviously for 2 reasons. One is the MI, inferior MI. 2 is the possible PE. And the precardial effusion. Let's talk about this RV. Remember we said for the cases with the inferior MI, you are not giving nitro because these are the very dependent. When you have RV hypofunctioning, they are very dependent to the preload. Anything that dropping that preload is causing trouble. You give the patient LASIK, you give the patient actually like the nitro, you give them anything that is caused that preload to drop, that significantly impact patient clinical picture. And you see the precardial effusion. The answer for the precardial effusion, what is the most important and first treatment for precardial effusion and tamponade? I know everybody's, maybe not everybody. Some of you guys maybe say, oh, precardial. That's not necessarily the right answer. The most important one is the intra-volume pressure increase by giving fluid. Remember, we talked that is all balance of the pressure problem. So if you are changing the balance by giving more fluid and increasing the pressure in the right side of the heart, so you delay the all component of the tamponade, and you have time to get the surgeon to move the patient, to transfer the patient, or if not, if his patient is unstable, obviously pericardiocentesis is the answer. I'm going to move on. We thought this was almost the same. So the high map, I'm not going to talk all of them. You guys know the fast exam, how that's affecting. But like abdominal aorta is another one that you do. How you do abdominal aorta? So abdominal aorta, you are just from subxiphoid to the umbilicus is going to be abdominal aorta. And what you do, you are aiming for vertebrae. You put the probe transverse in the subxiphoid area and you slide towards the umbilicus. And you forget about the aorta, focus on that vertebrae. If you see the vertebrae and everybody's vertebrae is midline, you see the aorta in front of it all the time. So then what is important is to look for that infrarenal. How do I know it's infrarenal? It's hard sometimes to find the branches. So you go all the way down to see bifurcation because majority of the aneurysm is happening proximal to that bifurcation, almost 90%, 95%, because that's actually infrarenal. So that's why we are trying to show when you are looking at the distal part of the abdominal aorta, we want to see bifurcation. When you see the bifurcation, it means you see the proximal to it, and you can confirm 95% of the possibility of this actually aneurysm, if you want to do only one. This is another picture of the aneurysm, and don't mix up this one. This is not, don't be confused with, this is a pseudolumen. Vertebrae here, pseudolumen here, and this is all bleeding in the wall of the aorta. This is intramural hematoma. So, as I said, I'm not going to talk about pneumothorax and fast and stuff because you guys know. I'm going to review a few cases with you. This is a case of the patient with the chemo, was on cancer, lung CA, is coming with chemo, hypotensive. What do you do when you're hypotensive with chemo? Diarrhea, vomiting. So we give him fluid. Patient got 3 liters of fluid, 62 years old, and the patient went in respiratory distress, cannot breathe. O2 sat dropped significantly. And these are the pictures we see. And I'm pretty sure everybody is going to tell me that I don't see the LV is moving. LV is not really moving here. LV is not moving. And LV, I see, base of the heart is moving pretty good, but the tip of the LV is not moving. Is this something that we should be worried about, like broken heart syndrome? Because this patient has cancer. And then you see this picture, the same video that you have in here. You see, this is the dynamic MRI, and it's showing the same picture in here. Okay, yes, this patient has broken heart syndrome and thoracic cardiomyopathy. This is another patient. This patient has 32 years old, had the cone biopsy for the cervix, is coming with the hypotension. And what you see here, this is the large effusion in the abdomen. And that large effusion around is actually like the right upper quadrant. And this patient has a ruptured uterus, basically. Looking for another case is 81 years old, fever, hypotension, UTI. Confirmed the UTI, confirmed that actually like that fever. Admitted to medicine. Senior say this patient is still hypotensive. I'm not comfortable take to the floor, so they want to do more of the testing. And patient more of the testing has a saddle pulmonary embolism, as you can see it here. So as you remember we said this majority of these cases they have multiple reasons for hypertension. Sepsis was correct. Patient has a UTI, but at the same time, what we see here, this is the saddle pulmonary embolism. This is another one that the patient is coming with the altered mental status and has the actually hypertension, as has the urosepsis. When you scan the protocol, you see that aneurysm that you saw earlier in this patient. These are extreme cases that actually we know that like the hypotension, the actual ultrasound is significant changing. Like these cases, some of them, honestly, This is mortality changes. Okay, that finding could really cause mortality for this patient if you were not doing it. Specifically in this one, this is very simple fast when you are looking at it. But this patient, when it's come to the emergency room, she is 26 years old, female, no trauma, no pregnancy, and said no pregnancy, no trauma, nothing else is coming, and immediately 10 minutes, 15 minutes into ED admission, collapsed dead in the ER, and cardiac standstill. And we look at the actual abdomen. This is the picture full of well, we still think this is ectopic because this is a patient, even patient we know is not, they said no pregnancy, but who knows. But at the same time, when we look at the aorta and the part of the protocol, we see the aorta is super narrow, super small. This patient has splenic artery aneurysm ruptured. That is rare. Normally you see in the patient with pregnant patients. And at the time that I saw this one, probably I think more than 100 cases of splenic artery aneurysm was reported, and 60 of them was reported in autopsy. So it's just a super kind of high mortality for these cases. And I think this is the patient. Oh yeah, I have this patient permission, and it just sent me this patient. We got this one, got the resuscitation, stays in ICU, and actually 6 months later got married. And the patient has been pushing on the chest for quite a while, completely hard, this cardiac standstill by definition means not coming back. And this is the pictures. This is another case of, I think the patient is like 26 years old, HIV positive, antiretroviral treatment, has 2 years of like the on the hypertension, and his hypertension is arterial hypertensive, and had history of tuberculosis 2 years ago. Is in cases of in 2016. And what you see here, you see the RV is dilated in these two views more than everything else. And when you scan in here, you see the aorta is jetting actually significant jet of the aortic regurgitation in here. And you have significant mitral regurgitation in here. I'm sorry, tricuspid regurgitation in here. Tricuspid regurgitation, RV dilation, trace fluid, and like the small RV. And you can look at the beautiful picture of McConnell sign on the tip of the RV in here. It's just like a beaking. And you see the clot actually in the IVC. This patient was treated for worsening CHF. Now you're dealing with this as a result of the P. CHF is coming, as you can see here, the right LV is absolutely not moving. When you have this auto contrast into the LV, that case is the ejection fraction less than 20% for sure. Okay, because the fluid is actually moving around itself. And you see this is along with the multiple B lines, so it's the typical of the cardiogenic shock. This is a case of myocarditis. 36 years old, is coming with URI and severe dyspnea, and been discharged and come back again. And the second time we scan the heart, and you see this is the heart. The LV barely moving. You see dilated. You see tons of B line. You see IVC is dilated, and that's the case. Another case of like, I'm going to just move on because we actually ran out of time already. So there's a lot of cases. This is a case of pneumonia and precardial perfusion and precardial fusion and the non-pneumothorax. We talked about this one earlier. This is another case of you guys don't have much cases like this. This 24 years old male, IV drug use is hypotension, O2 saturation less than 80%. What we see here, we have the case that has significant, is hypotensive, RV superdilated, and then you see a vegetation on the top of the actually tricuspid valve. with severe pulmonary hypertension in this case. You scan the IVC, looks like actually dilated. You see a lot of B lines here in the actual pro line. And that's case of the patient was decompensated, septic, and cardiogenic shock. There's another one of the actually look at CDC, not the best case, not best pictures, but you see a large effusion around here. This patient is come from the dialysis, and they actually, like when we in the emergency room, collapsed and start CPR, and we see this picture, started doing this actually cardiosynthesis and resuscitation, found out the patient had they changed the catheter the day before, and they actually had the perforated right atrium. Post-cardiac arrest cases. Post-cardiac arrest cases, remember, this is some component of almost broken heart syndrome without ballooning, because you have a frozen LV, basically, as a result of too much epinephrine that you are given. So this case is important to not to really intervene necessarily with the ST elevation or stuff like you want. So it's important to know to just give some time for the patient to have a actual movement. This is one for the epinephrine effect. The other thing is that because the LV has been down, RV is getting super dilated. So don't mean that patient has pulmonary embolism. So if you see, those are the two pitfalls we see with the patient with the cardiac arrest and a shock. So those are the ones that you need to consider. Is this really as a result of too much pressure we are giving? Or is that the patient too much of the, like because of the LV has been down, it means the most common reason for RV dysfunction is LV dysfunction. So if you have LV dysfunction and not functioning for quite a while, RV is going to, every fluid is going to build up around behind the RV, and that makes it the dysfunctional RV. So the bottom line, this is Rush protocol that we talk is just a high map to just do, to remember it. Don't forget DVT is also part of it, especially if you think about the pulmonary embolism. One way to look is just go and actually take, if you see the DVT, you can start the thrombolytic at the beginning. Okay, so you're looking for the focus sonography. You're not like just need to have a complete set of everything that you want to get. This protocol is helping with patient in about, like I can say normally about 50% of the cases is significantly impact. About like 20% is moderately or just like a little bit impact. And 30% of the cases, really, there is no impact for the ultrasound. But how you differentiate which one is which, you cannot unless you're doing it. So don't be disappointed if you are scanning the patient and still you are not finding and you are not changing your management based on that. But how you know which one is more important? The cases that they are extreme, the patient that they are been down for a long time, the patient that the disease has been going there for quite a while, those are the extreme ones that actually that helping you. I stopped in here and I'm going to look at the chat to see if there is any question. I'd be happy to answer. And as I said, there's a lot of stuff I did not discuss, including like FAST exam, including the pneumothorax, DVT, but we try to focus on the most important one, the cardiac, and make sure you guys got that one.
Thank you so much. The floor is now open for questions, comments.
Yeah, feel free to open your microphone and talk and tell us what you think. Helpful, not helpful, what do you want us to do next? If you are itching for any specific topic for next time, tell us now. So my email address is there. Please feel free. I'm going to share this slide also with you guys. feel free to reach out if you have a question, and I'm happy to answer. And it was really pleasure meeting you guys all, and hopefully I see you guys all in October, November during the annual meeting, hopefully.
Thank you so much, Dr. Hamid.
Absolutely.
So next month we have another meeting. It will be on the 27th of March, and the topic is ultrasound use in procedures.
Excellent.
So let's prepare for that as well. Thank you so much for attending.
Absolutely. Thank you.
We will meet in a month's time. Bye, everybody.